Okay, so that was a poem by Rabindranath Tagore. It's an Indian poet. So he said, "My love, my heart, let this time of parting be sweet. Let it not be a death, but completeness. Let your love melt into memory and your pain into songs. Let your flight through the sky begin, the unfolding of wings. Let the last touch of your hands be gentle, like the flower of the night. Stand still, oh beautiful love, for a moment, and say your last words in silence. I bow to you and hold up my candle to give light to you on your flight to freedom." The poem engages with themes like of life, death, and even use nature to compare with death and dying. These three themes are easily linked to one another, creating an image of life and its entirety, and how death touches everything and everyone. The birds, the flowers, they encounter death just as human beings do. So the poet uses the uses this part of nature as examples of how peaceful, still, and silent uh, death can be. This slide shows us the Philippine statistics from the Philippine Statistics Authority on the causes of mortality, the top 20 causes of mortality in the Philippines from January to April 2023 and 2024. It shows ischemic heart diseases on top, followed by neoplasms or cancer or malignancy. Third is cerebrovascular diseases. In 2021, the cancers were actually on the third. So now on the recent, they're on the second slot. It is estimated that in developed countries, about 70% of all deaths are preceded by a disease or condition, making it reasonable to plan for dying in the foreseeable future. So you, you can identify if the patient is dying or terminal. This is what it means. So you can actually plan. Although cancer has served as the paradigm for terminal care, but it is not the only type of illness with a recognizable and predictable terminal phase. So palliative care can actually be used in all specialties and subspecialties because heart failure, COPD, chronic liver failure, and even dementia, and many other conditions have recognizable terminal phases. A systematic approach to end of life care should be part of all medical specialties because of these recognizable terminal phases. Many patients with illness related suffering also can benefit from palliative care regardless of prognosis. Ideally, palliative care should be considered as part of comprehensive care for all chronically ill patients. Palliative care can be improved by coordination between the caregivers, the doctors, and patients for advanced care planning, as well as dedicated teams of physicians, nurses, and other providers. I'll mention the other providers later. Rapid increases in life expectancy in developed countries, so people live longer. This can be good, but this is also accompanied by difficulties in addressing the needs of the elderly or of the aging population. So the challenges could be more complicated conditions because of a lot of diseases can be found in the elderly. And aside from that, we all have the technologies to address those conditions at the end of life. The respirators, the dialysis, and then even the chemotherapy, this can be given to address these conditions that usually settings and approaches that relieve suffering for those with terminal diseases. So the question is usually, are you actually prolonging life or prolonging suffering or just delaying death? Those are the questions that we all need to answer as clinicians, and sometimes we share them with the patients and the relatives. In the early 1980s, about 70% of American cancer patients died in the hospital. Today, Um, Sorry, I think I'll turn off my camera. Okay, this is about the change in the site of death for patients, shifting from hospital death to home deaths, especially in patients for patients with cancer, COPD, and dementia. For instance, about 30% of deaths due to cancer in 2000 occurred in acute care hospitals, but by 9 years later, this figure has dropped from 30% to about 22%. How about you? Where do you want to die? Who can answer? Rara, where do you want to die?
Talk with my family, Doc.
So meaning at home.
Yes, Doc.
Okay. What do you think can possibly change your decision about dying at home? Although the statistics show that there's a shift. No, most people want to die at home.
Siguro, Doc, if I'm suffering from terminal ill disease and it's so very painful, siguro that time, siguro, Doc, sa hospital na siya, Doc.
Okay, and you still want your family there?
Dili ko ganahan makita sa song suffering, Doc.
Okay, so if you can see, there are factors that we may consider that would change somebody's decision regarding where do they want to die. So we should also understand the patients and even the families. Some reasons could be most of the patients would like to die at home, but then sometimes there's this discomfort for the family that there's no hospital setting. They cannot do the caring at home. Nobody's gonna do the caregiving. Those factors, and once they discuss it with the patient, then the patient may say, okay, I'll just stay in the hospital. Some patients may prefer that they're in the hospital with the benefits of the hospital staff, but they want their family there. But again, that may also change in certain situations. But the hospice setting, when you say hospice, that's actually a setting that's like hospital setting, but the environment of being at home. So that's what the hospice trying to achieve. So if you can see, there's also a shift from hospital to hospice. We don't have the hospice is not a popular um, facility here. I don't even know if we have one really effective hospice, but we have doctors who see palliative care doctors who would be willing to see the patients at home. So the next slide would show us that there's increased use of hospice care. In 2008, 39% received such care, and cancer patients are most of the hospice users. And about 79% of patients receiving hospice care die out of the hospital. So it's not within the hospital, it's within the hospice. And around 42% of those receiving hospice care die in a private residence. So they are actually extending the hospice care in their homes. Central to this type of care is in an interdisciplinary team approach that typically encompasses pain and symptom management, spiritual, psychological care for the patient, and support for the family, the caregivers during the patient's illness, and even during the bereavement period. So palliative care extends beyond the death of the patient towards the bereavement period. So that's taking of the family. So everyone's suffering. So the family is also suffering. So you also take care of the family. Fundamental to ensuring quality palliative care and end of life care is to focus on four broad domains. The physical symptoms, is there pain? Is the patient bowel movement good? Is there no what's this bed sores? Is the mobility better? Psychological symptoms, the patient's having anxiety, social needs that would include interpersonal relationship, caregiving, and economic concerns. Are they still have enough money to support hospital care? Or is somebody going to take care of the patient at home? Are the relationships better? I think I shared with you that the patient with HIV and anal cancer who's been suffering more about the relationship with the family, especially with the father, more than the physical symptoms or existential or spiritual needs. So cancer is so big that it affects all these aspects of the person, mind, body, and spirit. So, and aside from that, terminal phases, not just cancer, can most of the time lead a person to spirituality or connect with the divine. Hmm. Okay, what's important is they are effectively communicating. The primary physician talks to the surgeon talks to the patient, and Okay, now I'm trying my data. Can you hear me?
Yes, Doc.
Okay. So these are all parts of the or members of the interdisciplinary team or multidisciplinary team. So for assessment and care planning, it should be comprehensive in focus on evaluating the patient's condition of all in all of the four domains that I already mentioned: physical, psychological, social, the relationships, and spiritual. And you would need different people, different specialties or agencies to address those things. Some doctors are also chaplains, so they can also address both. Avoid invasive tests for these patients. So invasive tests are best avoided in the end of life care, and even minimally invasive tests should be evaluated carefully. What's a minimally invasive? It can be just the blood extraction. So you have to limit all those things that can cause discomfort. So they should be evaluated carefully for their benefit to burden ratio. Can they actually, is it actually needed? Will it change your management or not? So even aspects of the physical examination that are uncomfortable and maybe unlikely to yield useful information can be omitted. So you don't need to ask the patient to stand up, or you don't need to examine the painful part if it won't really change your evaluation or management. So healthcare providers should also assess the status of important relationships. So that's part of the social aspect of the domain. No, even the financial burdens, the caregiving needs, and access to medical care. Some patients who decide to go home will have this anxiety. So how can we access medical care? So you have ensure them or assure them that they can always call on you, call your secretary, or go to the emergency room. But they usually prefer to have contacts with the doctor. Personally, I would give my number, so at least I would address that part. So relevant questions which will include the following: how often is there someone to feel close to? These are the questions that can guide you in evaluating or addressing the social aspect. How has this illness been for your family? Some families get closer, some families get more conflict. So it really depends. It's usually the family dynamics is affected by the disease. So how has it affected your relationships? How much help do you need with things like getting the meals or getting around? These are the things that part of the social aspect that the person may be struggling. How much trouble do you have in getting the medical care you need? Existential needs. This is more for the spiritual. To determine a patient's existential needs, provider should assess the distress status of the patient, the patient's sense of emotional and existential well-being, and whether the patient believes he or she has found purpose or meaning. So helpful assessment questions can include the following: how much are you able to find meaning since your illness began? What things are most important to you at this stage? So I had a patient who was a nun, and I she was at the terminal phase, or really dying in the hospital, and I tried to somehow whisper to this nun that it's okay to let go, and it's okay to let go of your suffering. But then she answered, but there's a meaning for my suffering. So it really depends on the patient's spirituality and what things are most important to you at this stage. So some patients, you may discuss about chemotherapy, you can give this treatment to prolong your disease, but then what's important to them may not be prolongation of life. What's important to them may be quality of life, their time with the patients, out not with the family, not time in the hospital. So you should consider all these things and deciding on what's best for your patients who are terminally ill. Particularly when an illness is life threatening, there exists the potential for many emotionally charged and potentially conflict creating moments, collectively called bad news situations, in which and empathic and effective communication skills are essential. Those moments include sharing of the diagnosis. That's part of the so-called communicating the bad news. Sharing, especially if it's a terminal diagnosis, both for the patient and the family. The discussion of the patient's prognosis. When you say it's bad prognosis, it's again it goes with the terminal diagnosis. The discussion of another one is treatment failure. When you sample, you've given chemotherapy after 3 cycles and then you evaluated, then it's good. There's partial response or there's stable disease. That's good enough. And then you gave another 3 cycles, and then you evaluated, and then you see that there's progression of the disease. There are new lesions coming out, or there's increase in the size of the lesion, and that's considered treatment failure. So discussing this with the patient and the family is another form of bad news. The consideration of de-emphasizing efforts to cure and prolong life while focusing more on symptom management and palliation. Even this can be considered a bad news. When you say your disease is really incurable, we don't really expect, although I would usually say nothing is impossible, but your disease is, statistics would show that this kind of diseases at this phase or stage is generally incurable. So with those statements, you don't really take away all hopes. No? So because sometimes those are the things that we just cling to, a little hope. So you can say that in your statement, but still you should be honest and discuss that we don't really expect significant prolongation of your life, but the goal of the treatment is to make you comfortable. That's symptom management and palliation. And advanced care planning. Advanced care planning is when you talk to the patient or the family on what's their decision in case death happens, or in case there's arrest, if they still want to be the patient to be resuscitated or given these kinds of diseases as part of these medications as part of the resuscitation. So you can discuss this with the patient, ideally with the patient, with the decision, and then or with the family in case the patient is incapable of communication. So an organized and effective 7-step procedure for communicating bad news goes by the acronym P spikes. P is preparation, prepare for the discussion, review the information that needs to be communicated, review the chart if the disease is located on the lungs, the liver, the brain. So you can discuss this, plan how you will provide emotional support, and rehearse the key steps and phrases in the interaction. Next is setting the suitable environment, the setting for the interaction. So ensure that the patient, the family, and appropriate social supports are present. They're all there. This is ideal. A lot of times, in our hospitals, you cannot. It's hard to set up a suitable environment. Sometimes we just talk on um, one corner of the room, or they would ask you to talk outside the door, in the on the lobby or on the corridors. It's not ideal. So if you can find a suitable environment, find one, and devote sufficient time. Ensure that the privacy, and ensure that there's privacy, and of course there's some privacy on the corridors. They start crying, and then a lot of people are passing by. It's not really suitable. And also to prevent interruptions by people, or your phone ringing, or notification sounds. So that can be avoided if you set up a suitable environment. And another suitable environment is to bring a box of tissues that you can offer in case they start to be emotional. Begin the discussion by finding out what the patient and or the family understand. So you can ask them, so mom, what do you understand about your illness? Sometimes if the patient, or if the family um, is asking you, doc, please don't tell the patient about cancer, about the diagnosis. Please don't mention cancer. And sometimes when I would ask the first question, like they're there, and then I would ask, so what do you understand about your illness? What do you know about your disease? And then if the term cancer comes from the patient, then it becomes not your problem anymore, because the word cancer didn't come from you. So you just need to confirm. So you ask about the what in trying to evaluate the patient's information, baseline information. You can ask, what did the doctor tell you? What did the surgeon tell you? Uh, and what do you think is going to happen? That's part of the information that you want to know about your patient's knowledge. Next is determine how they will comprehend new information best, and how much they want to know. If this condition turns out to be something serious, do you want to know? You can ask that. Would you like to tell me all the details of your conditions? If not, who would you like me to talk to? You can say these things. Some patients would like all the details. Some patients do not. Like I don't know if I share with you the young patients. I think she was 34, who's on stage 4 melanoma. And as I was discussing the the case with the patient. So she has been a patient for quite some time. She was given immunotherapy, and there's no response, and then it progressed. And when we're in the clinic, and I was already discussing that you have metastasis to the lungs, and it didn't respond to your treatment. But a family member asked, so doc, what's the stage that she is in? And then the patient actually said, no, 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 don't ask that. So that means she wasn't ready. Although I described the metastasis, it's here and there, but she wasn't ready to hear stage 4. So that's her option. And 5, provide the needed new knowledge accordingly. Do not just dump the information on the patient and the family. Check for the patient and family's understanding. A lot of times they don't really understand your medical jargon. So try to be use layman terms as much as possible. So you can say, I feel badly that you have to tell you this, but unfortunately, the test showed this, this, and this, and that. And I'm afraid the news is not good. Now, don't just say, okay, you have um, metastasis to the brain, and we should give chemotherapy, and radiation therapy, all those things. So be empathic. That's why the next step is allow for emotional responses. So empathy and then exploration. Strong feelings in reaction to the bad news are normal when the patient starts crying or the family starts crying. So acknowledge what the patient and family are feeling. So don't just suppress them. It's actually good if they are able to express. Catharsis is good. So remind them such feelings are normal, even if frightening, and give them time to respond. If they start crying, then give them time to cry. Remind the patient and family that you won't abandon them. So I'll be here until the end. Yeah, I'll be here in case you need me, in case they want to go home. So possible phrases to use can be, I imagine this is very hard for you to hear. You look very upset. Now tell me how you're feeling. Those things that can help. So, or you can say, I wish I have a different news. I wish that the results were different, but these are the results. And then another thing is we'll do whatever we can to help you. So um, we can give palliative treatment, we can give you painkillers, and we can give oxygen, and those things. Those are the next steps. So major barriers to providing high quality palliative and end-of-life care include the difficulty in determining both an accurate prognosis and the emotional resistance of patients and their families to accepting implications of a poor prognosis. So sometimes they the family would be resistant when you try to discuss terminal diagnosis. They would some patients may even go to acceptance before the family members. So and so like one situation maybe when the patient is trying to communicate that he or she is accepting the terminal diagnosis, and then the family member would say, no, don't talk about that. We would still go to Europe for a family vacation. We will still go to Boracay for a beach getaway. So those statements reflect to us that they're actually resistant to the poor prognosis. So a practical solution to these barriers is to integrate palliative care interventions or home visits from a palliative care physician or a nurse. And under this approach, palliative care no longer conveys the message of failure. So it's not failure. It doesn't mean that because your patient is dying, then we have failed. Okay, so there's always something that we can do, or when you say that, then that also uh, brings to them that you're not giving up hope. So continuous goal assessment should be done, and goals for care can be cure for a specific disease. So um, usually, if it's early, that can be the goal. But a lot of time, if it's disseminated, it may not be the goal. There are exceptions, like for certain cancers. One is testicular cancer, um, and germ cell tumors, which even at a disseminated stage can still be cured. Who knows Lance Armstrong? Lance Armstrong is an athlete who did Eraser, uh, did won Tour de France different number of times. He had actually stage 4 testicular cancer, but after going through extensive chemotherapy and radiotherapy, so he was cured and still able to win again after a successful treatment. So one goal is just prolong life. You don't really expect cure, but you want to prolong life, or even just relief of symptom. That's still a good cure. So you usually discuss this with the patient. Our goal for this treatment is this, and that, so that they won't have false hopes. So, or just delaying the course of an incurable disease. This is generally incurable, but when you give this treatment, it can prolong the disease or delay the death. So, adapting to progressive disability without disrupting the family, finding peace of mind or personal meaning. This is another goal, or dying in a manner that leaves loved ones with positive memories. So for the last one, part of your responsibility is to somehow make the death and dying environment um, less unpleasant for the family, for because part of the suffering is the family suffering. So in the room, you may not, if the patient is having agonal breathing or terminal breathing, which may show some changes in the skin, cyanosis. So you may not put on all of the lights for all the family to see. Huh? So if the breathing has this producing some sounds that are difficult to hear, you may put on some soft music. So that's part of your responsibility to make the dying situation less unpleasant for the family, because that would remain in their memories forever. So advanced care planning. What's advanced care planning? This is a process of planning for future medical care. I've mentioned this already a little before. In case the patient becomes incapable of making medical decisions. So you talk about this ideally if the patient is still fully communicable, can still communicate well, and can make decisions. So that it won't be a problem later about decisions if there's still a resuscitation, if you still go with intubation, respirator, and all those things. A 2010 study of adults 60 or older who died between 2000 and 2006, 42% required decision making about treatment in the final days of life. So they have to decide whether it should be resuscitated, there should be intubation, but 70% of the patients lacked decision making capacity. They're comatose, they're confused, they're not in their full consciousness, or they're incoherent or septic. So advanced care planning is important. Most patients expect physicians to initiate advanced care planning. So this is not just an expectation of the patient, but this is the responsibility, because we are the ones who evaluate the patients to be this prognosis and terminal. So you should know and you should discuss advanced care planning, and we'll wait for the physicians to broach the subject. So it's a sample discussion of allowing natural death or do not resuscitate. I think it's a failure of the physician to, when we say the family approach the physician and inform the physician that they're not aggressive anymore. So this discussion should be initiated by the physician. Patients also wish to discuss advanced care planning with their families. So you should give them time. Example, you're discussing about this, about advanced care planning, but give them time to decide. Okay, so you can discuss with your family. You may not have a decision now. I'll just come back for your decision, or I'll just endorse this with the resident physician who will follow you up later after your thorough discussion with the families. Patients with unrealistic expectations are significantly more likely to prefer aggressive treatments. That's why you should discuss your goals of treatment so that they won't have unrealistic expectations. So for the discussion of the advanced care planning with the family, I'd like to share that I had one patient before, um, that I have discussed allowing natural death or do not resuscitate or somehow advanced care planning with the patient. And the patient said, I don't want resuscitation. I don't want um, intubation and respirator when I'm about to die. And the patient was already at home, and the patient had difficulty. Uh, the daughter who's scheduled to be married was also there with the patient, with the mother at home. And when the mother was terminal or really about to die, you would know that the patient is about to die. The daughter actually brought the mother, of course, without her knowledge, so to the emergency room and asked the patient to be resuscitated and intubated. And then the patient woke up after intubation and was surprised that she was already intubated and got mad, of course, with the daughter. Why did you ask me to be resuscitated and intubated when we have discussed this already? So that's somehow a selfish decision for the daughter. Like you would ask your mother to, it's like asking the patient to, can you suffer a little longer so that you will be there, you would still be alive during my wedding, or something like that. So anyway, the patient eventually died after a few days or just even hours, because again, but the patient was intubated already. So they decided on allowing natural death. But then that's the importance of discussing advanced care planning with the patient and to include the families. The types of documents that you can use would be living will or instructional directives. Instructional directives should be detailed for no intubation, no giving of inotropic medicines that can resuscitate the patient, things like that, or designation of a healthcare proxy in case I cannot decide during those times. Then my husband will be my proxy, so that they won't argue on who's gonna decide. Huh? So, but if you look at the legal point of view, if the patient is married, then the spouse would be the first line. Then, if the spouse is in there or gonna decide, then you go with the eldest child, and so on. The interventions for terminal ill patient, you should try to remember physical symptoms, but also do not forget the psychological symptoms. No, anxiety, depression, hopelessness, meaninglessness, irritability, and yeah. So pain at the end of life, there's really reason to doubt a patient's report of pain. If the patient says, I have this pain, believe the patient. Do not say, uh, um, you might be just creating this scenario of having pain. Believe the patient if their patient reports pain. And the three-step approach: first, the non-opioid analgesics. Second will be the non-opioid analgesics can be paracetamol, the NSAIDs. Okay, mild opioids. What's an example of mild opioid? Tramadol. If you know tramadol, that's a mild opioid. And strong opioids, of course, the morphine, oxycontin, with or without adjuvants. The adjuvants can be anti-anxiety or for neuropathic pain. Addiction or excessive respiratory depression is extremely unlikely in the terminally ill. But if you check on the opioids, that this can be a lot of the fears of the family who go to Google or with family members who are medical, like nurses, but know that these are actually extremely unlikely. So this would not um, block you from using your opioids. So your goal is not to cause respiratory depression or addiction. Your goal is to relieve the pain. And so addiction is the least of your concerns. For continuous pain, opioid should be administered on a regular around the clock basis. So do not give it like as needed. So give it every 4 hours for regular morphine or every 12 hours for oxycontin. So they should not, okay? And your goal is not to relieve the pain that moment, but to prevent the pain from coming out. And you should also give rescue medication. What's rescue medication? In case your example, you give your morphine every 4 hours, but then even after an hour of taking the morphine, so not yet 4 hours, the pain recurred or the pain persisted, then you can give another morphine or another medicine in between. So that's called rescue medication. So you don't have to wait for the 4 hours before you give the pain medication. So this should be part of the pain management to give rescue medication. You cannot just say, "Sir, we cannot give you another one because we still need to wait 4 hours." Okay, so that's like prolonging or extending suffering for another 4 hours. So it is inappropriate to start with extended release preparations. Like extended release will be giving it for a medication that's given like once a day or every 12 hours. Those are extended release preparations. So you start with short acting preparations. Short acting preparations will be like every 4 hours, and then plus the rescue. Once the pain relief is obtained using short-acting preparations, that's the time you can switch to extended release preparations. So once you have the dose for your patient, then you can shift to the equivalent dose for extended release preparations. But then again, you should continue evaluation, because sometimes if the disease is progressing, then the pain pain medicine requirement could also progress, could also increase. Incident pain. What's incident pain? It's such as pain that occurs such as during movement or dressing changes, in case you expect the patient to be transported somewhere for some reason, or you're dressing the wound. So incident pain. That's called incident pain. So for this, once you should give short-acting preparation and give it before your predictable episodes. So before you transport the patient, give medicine because you expect the patient to be in pain as you transport, or as you do the dressings of the wound. Opioids have no ceiling effect. There's no such thing as you've reached this, so you cannot give anymore. So unlike the NSAIDs, so the appropriate dose for opioids is the dose needed to achieve pain relief. If pain relief is achieved by using 5 milligrams, then that's it. But if you have to increase to 100 to 200 milligrams, that's still okay. There's no ceiling effect. Seriously ill patients who require chronic pain relief rarely become addicted. So suspicion of addiction should not be a reason to withhold pain medications from terminally ill patients. So even if you suspect addiction, that's the least of your concern. You can give medications. So they would not be living for a long time and get addicted. Okay? So nonetheless, patients and families may withhold the prescribed opioids because of this fear. So also know that the relatives may not give the patient and ask the patient to continue suffering because they would fear addiction or dependence. You should discuss this with the patient and the families. So physician and healthcare providers should reassure the patients and families that the patient will not become addicted to opioids if they are used as prescribed for pain relief. So if there's pain, so the medication will go to the pain receptors, not to the brain where it will produce um what's this, euphoria and all those things. But then also know that opioids have side effects, and the most common will be constipation. Almost 100% of the patients in opioids will have constipation. So you usually give together with the opioids laxatives or nausea and vomiting. So you can give together with the opioids some anti-nausea and drowsiness. Drowsiness can be a welcome side effect because some of them may have difficulty sleeping. What are adjuvant analgesic medications? They can potentiate the analgesic effects. They can be because of neuropathic pain. So you can give pregabalin, gabapentin. These are called adjuvant medications. Some for some steroids can be also adjuvant, and radiation therapy can be given as to relieve, to palliate symptoms like for bone metastasis, painful bone metastasis can be given radiotherapy, and of course, brain metastasis. Those who have the strength and the love to sit with the dying patient in the silence that goes beyond words will know that this moment is neither frightening nor painful, but a peaceful cessation of the functioning of the body. Watching a peaceful death of a human being reminds us of a falling star, one of a million lights in a vast sky that flares up for a brief moment. These are words by Elizabeth Kubler-Ross on the book on Death and Dying. Elizabeth Kubler-Ross is a popular author and a doctor who focuses on death and dying. So if you want to know or read about death and dying, go for the books of Elizabeth Kubler-Ross. Constipation is, as I have said, one symptom, side effect, can be side effect of your treatments, and other causes could be hypercalcemia, antidepressants, or inactivity because they don't move, or even poor diets. Nausea can be seen in about 70% of patients. This can be because of metabolic changes or bowel obstruction because of the disease, or even because of the constipation or infection or GERD or some brain metastasis, or even because of your medications. Radiation therapy and chemotherapy can cause nausea and even anxiety. Dyspnea is another symptom that's common during the terminal phase. Of course, you can give oxygen supplementation. Fatigue, you have to assess if the patient is anemic. And lastly, what's palliative sedation? Palliative sedation is when patients, this can be given. You can put the patient to sleep to palliate, and you can give this when patients experience severe symptoms such as pain or dyspnea that can be relieved, that cannot be relieved by conventional interventions, or experience acute catastrophic symptoms like uncontrollable seizures. Then palliative sedation should be considered as intervention of last resort. If you have done everything and the patient's still suffering, then you can put the patient to sleep. So palliative sedation is used in distressing situations that cannot be addressed in other ways. Typically, palliative sedation should be introduced only after patient and family have been assured that all other interventions have been tried and after the patient and their loved ones have been able to say goodbye. So give them the chance to talk to the patient, to say goodbye, to say those words, because they would also suffer if they have words left unsaid. No? So give them time to say goodbye, and you can give palliative, give these medicines to cause to have palliative sedation, opioid, midazolam, or even propofol, which is like anesthetic. Allow me to share this poem, personal poem. I don't know, but it's supposedly titled Beauty. I don't know what happened to the font. No, so that's beauty. Nobody owns anybody. Nobody owns anything. Yet we are given precious moments to be holders, not owners. So when it's time to let go, when things, people, or moments must flow, surrender to the being, for he knows what he's doing. Be free of greed, just delight for the beauty that you held, even for a night. How much more for a lifetime can't you just see the honor of holding it and the dignity to set it free? Thank you. So that ends my talk on palliative and end of life care. Any questions?
Hi, Doc. I have a quick question, Doc.
Okay.
This is regarding the advanced care directives, Doc. Ba? I'm just curious for our LGBT patients, Doc. Can we give them the option to give the decisive powers to their um kanang partners, Doc?
Yes, yes, that can be designated, as I've said. No, it can be designated to a person. It may not be said that the legal. I said the legal. The law would just tell us, the legal
Just
guide would tell us that it's the spouse and then the eldest child, but it can be designated. It can be designated, and the designation should be followed if it's advance directive, because advance directive are signed by the patient and even by lawyer. So it's legal. It becomes legal document that should be followed. Some hospitals like Chonghua, I saw before in the website of Chonghua Mandawi, because Chonghua Mandawi initially was planned to be a cancer center before it became a general hospital. So they have uh, a clickable link on advanced directives on their website, but it's not so popular in the Philippines. So yes,
that's good to know, Doc. Thank you po.
any other questions? How is everyone? I hope everyone's safe. Rara, is everyone
Okay
safe?
lang, Doc.
Someone?
Yes, okay na,
Okay,
Doc.
that's good. And your family? Uh, safe. Um, anyway, this series of earthquakes is really causing a lot of anxiety, even with some of my mentees. So it's expected, but it's okay not to be okay. Just accept your emotions or express, talk to somebody. No? Thank you for attending the today's lecture. So I'll see my SGD group after a few hours. Thank you, everyone.
Thank you,
Salamat.
Doc.
See you later.
Thank you,
Thank you,
Doc.
Doc.
Thank you, doctor.
Thank you, Doc.
Thank you, Doc.
Thank you. Bye.
Bye.